Good morning, one and all. Myself, Alka pursuing my third MBBS from Kanachur Institute of Medical Sciences, Mangalore. In the platform of International Online Video Case Presentation Competition, I am up here to present a case of Mr. Akash Tripathi, who is 35 years old male, residing at Ullal, Mangalore. His teacher by occupation was admitted on 2nd February 2020. His chief complaint was sudden onset of chest pain since 2 hours. History of presenting illness. Patient presented to the emergency department with chest pain which was since 2 hours. The pain was sudden in onset and progressive in nature. It was a sharp pain and was felt more when tried to breathe deeply. He also gives a history of shortness of breath from past 1 hour. He complains of chest discomfort. On further eliciting the history from informant, it was known that he had 2 episodes of blood in sputum and had travelled back from UK a day before, after which he developed left leg pain and swelling. He had no other comorbidities. There is no history of tuberculosis or any seasonal variation in breathlessness. Past history. No history of hypertension, diabetes, tuberculosis, asthma, chronic obstructive pulmonary disease or any other malignancies. There is no history of prior surgeries. Family history. No history of similar complaints in the family. Personal history. He takes mixed diet, his appetite was reduced, sleep was not adequate, bowel and bladder habits were normal, no substance abuse. Coming to the general physical examination, the patient was conscious, cooperative and well oriented to time, place and person. He was moderately built and moderately nourished, but was drowsy and sweating profusely. When vitals were checked, pulse was 130 beats per minute with regular rhythm, increased volume, normal character with no radioradial or radiofemoral delay. All peripheral pulses were felt. Blood pressure was 140 by 90 mm of mercury over right brachial artery in supine position. Respiratory rate was 26 beats per minute. Abdominothoracic type of breathing was seen and pursed lip breathing was seen. Temperature was 99.2 Fahrenheit in right axilla. His jugular venous pulse was not raised. Oxygen saturation was 78% on room temperature. Pallor and left pedal edema was present with redness in the calf region. No icterus, cyanosis and lymphadenopathy. There was no external markers of core pulmonale present. No external markers of tuberculosis. Coming to the systemic examination, on doing respiratory system examination of upper respiratory tract, oral cavity, nasal cavity and pharynx was normal. Lower respiratory tract examination, on doing inspection, there was no tracheal deviation, apex beat was not visible, chest was bilaterally symmetrical and barrel-shaped. Intercostal spaces were increased. Accessory muscles of respiration were in use. There was no dilated veins, visible pulsation, scars and sinuses. No spinal deformity or drooping of the shoulder. Chest wall movements were bilaterally diminished and symmetrical in all areas. Coming to the palpation, no tenderness was felt and local rise of temperature over the chest. All inspectory findings were confirmed. Unable to palpate the apex beat. Measurement of the chest anterior-posterior diameter was 30 cm, transverse diameter was 31 cm, chest circumference on deep inspiration was 102 cm, on expiration it was 100 cm, hemithorax right side was 50 cm plus 1 cm and on left side was 50 cm plus 1 cm. Chest wall movements were bilaterally diminished and symmetrical in all areas. He was tachycardic and tachypnea. Vocal fremetus was decreased on both sides in all areas. There was no palpable rhonchi or rub. On doing auscultation, normal breath sounds were heard with expiratory phase. Diffuse polyphonic wheeze were heard on both sides. Crepitations were not heard. Vocal resonance was diminished in all areas. On doing percussion over the clavicle, it was found resonant on both sides. Coming next to the cardiovascular system examination, S1 and S2 was heard with no murmurs. On doing abdominal examination, abdomen was found soft and non-tender. Lower border of the liver was palpable below the costal margin. Upper border was palpable at 7th intercostal space during expiration and 8th intercostal space during inspiration along the mid-clavicular line. Further, on doing the central nervous system examination, higher mental function, cranial, motor and sensory nerves were found normal. Now, what is the diagnosis? Acute myocardial infarction, pneumothorax, pulmonary embolism, cardiac tamponade. Investigations was done to come to the final diagnosis, which included complete blood count. D-dimer test was done, which showed the presence of blood clot. USG of the left leg showed thrombus in the deep veins. Chest X-ray was done, which showed regional oligemia, Westermarck sign, Hampton's hump, and central pulmonary artery enlargement, Fleschner's sign. ESG findings showed sinus tachycardia, large S wave in lead 1, Q wave in lead 3, and inverted T wave in lead 3. CTPA was done to confirm the diagnosis, which showed saddle thrombus. Hence, massive pulmonary embolism was confirmed. And now, the management. When pulse oximetry showed sinus tachycardia, oxygen was started at 62 per minute through face masks. After few minutes, central pulse was not felt. Therefore, Code Blue was alerted as per our hospital protocol. Code Blue team arrived, resuscitation started, and CPR was continued. He got intubated, thrombocytes was given, and ventilating support was continued. After 2 cycles of CPR, injection adrenaline 2 ampule intravenously was given, after which patient revived and vitals started improving. Follow-up was done every day, then was extubated after 2 days and got discharged after 5 days in stable condition with no deficit. I would now conclude my presentation by acknowledging Dr. Augustine K.M., Professor and HOD of Emergency Department in Kanachur Institute of Medical Sciences. Thank you, sir. I pay my special regards to you. Thank you all. Let's remember, it's never too early or too late to work towards being the healthiest you. Be healthy. Thank you.